Now, moving on to our third section, that is after the clinical evaluation, we have to go for the management. Whether we need to repair it primarily or do a delayed reconstruction, that is what we'll be discussing in this section. We'll be discussing preoperative care and wound exploration, extension and flexor tendon repair, and post-operative management of the flexor and extensor tendons. Now the important point is that this is a diagram which is actually show how the flexor tendon is actually attached over here. This is the FTP attaching over here. There are 5 pulleys, and at this point the FTP and FDS are in the same sheath, and FDS comes in attached over here. There are 5 pulleys called as annular pulleys, that A1, 2, 3, 4 and 5, and it starts with at this level of the head of the metacarpal. A1 starts at this level, and then it's A2, and then it becomes A4 and A5, and like this. But what's important is the 2 pulleys are highly important, that is A2 and A4 pulleys. And when we are inspecting that wound, for example for laceration, we need to look at it whether the A2 and A4 pulley are intact or not. Then there are 3 cruciate pulleys are in between as well, that is this is the C3 over here, C2 and C1. Between A1 and A2 is the C1, between A3 to A3 and A4 is C2, and A4 and A5 is always C3. So it's important to analyze whether A2 and A4 pulley is intact or not, and that is how we're gonna divide it into the zones as well. When we are dividing this into zones, now this is where the actually FDS is attached. It is attached to the base of the middle phalanx. All that zone distal to that becomes a zone 1 injury. If there is a zone 1 injury, most likely the only FTP is injured. If it's a zone 2 injury, both FDP and FDS can be injured as well. Now this starts from where the FDS is actually attached all the way till the A1 pulley, which is attached to the base of the head of the metacarpal, or it is called as till the proximal distal crease of the palm. This becomes the zone 2. From the distal crease of the palm or from the A1 pulley level, this descends down till almost at the level of the thumb, where thumb joins the palm. This area becomes a zone 3. From this area till the distal part crease of the wrist, it becomes zone 4. Wrist joint actually is this, zone 4 most of the time, and then in the forearm it becomes the zone 5. We need to explore the wound. Why we need to explore the wound? Because we need to be sure whether there is an isolated injury, is it a complete rupture of the tendon or a partial rupture. Nerve and vessel repair is done if they are injured, and there has to be a very strict protocol for their repair as well. If extensor tendons are also injured, they also may need repair as well, but before that we have to give them assessment as well. Flexor tendons may also need repairing, and usually they are repaired, especially if they are zone 2 injuries. And then we need the closure. Now on this side, this is actually showing how we can extend the incisions. Sometimes you have to use the creases which are present in the body. Other is option we can go for Z-type incisions, in which so that later on skin can get contracted. This does not affect the movement of the tendons, and easily the tendons can glide over the pulleys. Now coming to the preoperative care. If the wound is contaminated, it has to be rinsed with sterile saline. Antibiotics are given actually as well as per the local protocols. And important is that we can keep the hand lightly splinted in the functional position, and wound cover with iodine soap dressing. For clean, and antibiotics are omitted and avoid so that antibiotic resistance does not develop over time. Prophylaxis is done against tetanus. Then again, depending upon whether the tetanus prophylaxis was done, if done within 5 years, we don't need to do it again. Now coming to the wound clean under the general or regional anesthesia. If there is a deep dirty wound, then you first of all you need to clean the wound as well. And pneumatic tourniquet is essential unless crush injury. Crush injury is called as because there is already a lot of ischemia in the crush injury. Now we do not apply pneumatic tourniquet only if there is a crush injury. Otherwise, all surgery is usually done in pneumatic tourniquet. Incisions are not directly crossed in skin creases or interdigital web. What's important is called as lines of Langerhans. Usually if the incisions are parallel to these lines, it will heal properly and will cause not much of a scar formation. The incision should be perpendicular to these lines of Langerhans should be avoided. Now coming to the, if it's an enlarged wound and loose debris is just picked out, and if there is a fractures also associated with it, they're usually reduced and held by mostly the K-wires are more than enough for the hand fractures or metacarpal or the phalangeal fractures. Now coming to the nerve and vessel repairs. If the joint capsule or ligaments are repaired, then artery and vein may need to be repaired as well, especially if it's associated with neurovascular compromise. Needed if the hand or finger is ischemic, done with usually with operating microscope, and if there's a gap in the vein, this is usually bridged with the if there's a gap in the artery, is usually bridged with the venous graft. If there are severed nerves as well, especially the digital nerves, they are usually sutured under the operating microscopes, which can do this. And nerve graft may also be utilized, but also usually rarely required. And dissolvable nerve actually guides to the bridging gap, so that where you need to suture the nerve, that actually tells you where that's degenerated. Now coming to the extensor tendons. Sometimes after the artery and nerve repair, the first thing you have to repair is the actually extensor tendons. Although it's not easy, but you need a meticulous know-how as well as skill to do it. And sometimes the results are not as reliable as well. But it's important is to once you have repaired it primarily, then you need to apply a splint so that to decrease the movement or the extension at the this site. So therefore you have to keep the joint in full extension, especially at the metacarpophalangeal joint as well as at the wrist joint. And why? So that there's minimum amount of tension over the extensor tendons. Now coming to the flexor tendons. It's sometimes even more challenging, but once artery, vein are repaired and extensor tendons are repaired, then we can go for the flexor tendon repair. And usually they are repaired. Primary repair, if there is a laceration, this are acute trauma, primary repair is very much possible. Unless there is a deep wound, a large gap, then probably we have to go for a delayed repair or secondary repair. Tendon must be strong and accurate, and tendon repair, why it is called as, there is different methods of doing the repair, 4-strand, 8-strand repair, in which actually, and then you have to repair the epitenon as well. A2 and A4 pulleys are repaired or reconstructed. Amputation of the finger is to be avoided, and ring avulsion especially is actually a special case. Sometimes if the ring finger is involved, then we can just do the amputation as well. Otherwise, for most of the fingers we have to go for repair and reconstruction. Wound and washed out and loosely closed if there is already present, and if we have already dealt with the wound previously, then we can just simply go for the primary repair of the flexor tendons. Tourniquet is deflated, and bipolar therapy is actually used for the meticulous hemostasis. Once the hematoma formation actually risks the wound failure, infection, stiffness, so we have to avoid it. Skin closure is either by direct suture or without tension. Closure by skin grafting or skin flap is actually done. If there is already a lot of skin wound over there, we have to go for skin grafting as well. And sometimes severely mutilated finger is sacrificed. If there is no hope of actually reimplantation, or there is no hope of survival of that finger, we may have to go for amputation as well. Now coming to the pulp and fingertip injuries. Fingertip injuries are very important because wound should be thoroughly cleaned if they are open, covered with non-adherent dressings, and wound should be inspected infrequently. Thumb length should never be sacrificed. Why? Because thumb is actually a very important function of the hand and actually provide the grip and the pinch function. When the bones are shortened, they are usually shortened so the advancement flaps can be done in form of a neurovascular island flap, or advancement flaps can be done especially over the distal tip of the fingers. Nail bed injuries are also very common, especially in the pediatric age group, but what's important over here is the wound has to be properly explored, washed, and we have to look at the fractures of terminal fillings as well. Meticulous repair of the nail bed under magnification is very important, because once the nail bed has to be properly reconstructed, then if there is any loss, split thickness nail bed graft can also be done, or if this is associated with the physeal fractures, then we can go for a K-wiring of the fracture as well. Now coming to the dressing and splinting of this. Wound is covered with single layer of paraffin gauzes and wool roll. Wrist and hand is actually held in the position of safety. If it's a flexor tendon injury, then we've repaired the flexor tendons. When then probably the wrist is held in the dorsal splint with 20 to 30 degree of flexion. Why? Because there should be no tension at the flexor side. MCP joints are held in full flexion, and interphalangeal joints are held in full flexion. This is the position of the wrist after the primary repair of the flexor tendons. Same is the case with the extensor tendon repairs. The metacarpophalangeal joints are actually flexed about 30 degrees. Interphalangeal joints are held in extension, while the wrist is actually held in some degree of extension so that there is minimum tension over the extensor sides of the tendon. Now coming to the post-operative management. Immediate aftercare, hand has to be kept elevated and roller towel or hand sling. Sling removed several times a day for the exercises. This can be done as well. And antibiotics may be continued if there was already a deep dirty wound, but if it was a clean wound, we don't need to even start the antibiotics straight away. And much elbow flexion can be done so that the venous return should not be hampered. What's important is that those joints which have been immobilized, all other joints should be freely mobile, and patients should be encouraged to do the physiotherapy. But there is a definite protocol called as Kleinhardt and Duran protocol, which is usually followed for flexor tendon injuries. Now coming to the rehabilitation. Splintage allows many joints to be excised. Most extensor tendon injuries are actually splint for at least 4 weeks, maybe required more than that. Dynamic splintage is in which we can go for physiotherapy of the repaired tendon, and various protocols of the flexor tendon are actually applied. As I told you, there is a Kleinhardt protocol and Duran protocol. And tissues are, once they healed, hand can be used for complex tasks. What's important is the rehabilitation is as important as the repair of the tendon, and we have to be very meticulous regarding the rehab so that the re-rupture of the tendon does not occur. Now coming to another problem is called the replantation. In case if this injury was severe enough and amputated part has been removed from the body, or a finger or a thumb has got amputated due to injury, that part has to be wrapped in the sterilized saline gauze, placed in a plastic bag, and for a finger, the cold ischemia time is 30 hours. Warm ischemia time is less than 6 hours. For hand and arm functions, the cold ischemia time is about 12 hours, and warm ischemia time is almost the same as 6 hours for most of the thing. When can they be implanted? Usually social and professional requirements. For example, the patient is a laborer or a skilled worker using hand a lot of time, or condition of the part of there was a clean cut, then yes, but if it's mangled, it cannot be done as well. Or what about if the patient comes within the warm or cold ischemia time, then probably we can think of reimplanting the finger. Relative contraindications usually include single digits too badly if replanted, because a single digit do not survive very well. There is high complication rates with replantation, such as stiffness, non-union as well. And severely crushed injuries, a mangled or reversed finger may eventually still become necrotic despite replantation. So eventually you have to go for amputations. So instead of going for such an aggressive surgery, we can straight away go for early amputation in these kind of situations. In this section, we have briefly gone through the management of the tendon injuries and how initially the first and foremost the wound care. We can have to go for copious quantity of normal saline can be used to clean the wound meticulously, and once the wound is clean, we can apply the tourniquet to repair the flexor and extensor tendons as well. If there is associated neurovascular injuries as well, we may have to go for arterial repair as well as the nerve repair. Our nerve grafts or venous graft for the arterial repair can also be utilized. What's important to know is that once the repair is being done, we have to apply a dynamic splint and start a specific rehabilitation protocol, which is for either for extensor or flexor tendon injuries, which is as important as the repair itself. Thank you very much. Keep watching sqadia.com.